Welcome, everybody. Good afternoon. It's a great pleasure to introduce this ESGE Satellite Symposium. We want to thank first Medtronic for supporting this symposium as a major sponsor. And let me introduce myself. I'm Alessandro Repici. I work in Milano. And so glad to have two panelists working with me this afternoon. One is the famous Dr. Cesare Hassan from Roma. He is one of the most famous and genius guy in the field of colonoscopy in the world. And the other panelist, again, as like Cesare, is a very good friend of mine. Is Pradeep Bhandari, is professor of gastroenterology at Portsmouth. And also Pradeep is a super expert in the field of colonoscopy, therapeutic colonoscopy. So why are we here? We are here because there is a lot of things to say, a lot of innovation coming in the field of colonoscopy. As you can see, the title of the Satellite Symposium is Improved Polyp Detection for Everyone. Whatever is your skill, whatever is the scope is using, is a matter of being GI genius. And I'm so glad to announce that thanks to a very generous grant, there will be a big award supported by European Society of Gastrointestinal Endoscopy. And this award will allow a lot of teams in endoscopy to make new research program in the field of AI and colonoscopy. And I'm also so glad that the two most important people for the award are here, because Cesare is the treasurer, so the guy controlling the money of the awards. Yes. I think that the grant provided by Medtronic is super big, I think a couple of millions. And also the other very powerful guy controlling the awards and telling us more details about the award is Pradeep Bhandari, who is the chairman of the scientific committee of the ESG. So welcome, guys. Thanks for joining me. It's a great pleasure. I'm missing you so much in person. We are not meeting any longer. We used to meet every weekend almost. Now my presentation. So if I can have control of the slides, David. Okay, so very few slides to introduce the topic of artificial intelligence for colonoscopy. These are my disclosures related to this topic. So this is the most important. So you know that almost all European countries, they have adopted nationwide colorectal cancer screening program. So despite this adoption in the last few years, saw a massive increase of numbers of patients being screened for colorectal cancer, either with the direct colonoscopy or with the FIT. Still, the estimation of this quote, these projections, they come from European Union. Still, the projection of the incidence and mortality for colorectal cancer are extremely terrible. I'm very worried about this number. I'm very worried to see Germany, Italy, UK, France, Spain, so the countries with the largest population still being deeply affected by the number of colorectal cancer, by mortality from colorectal cancer, which is a cancer that can be prevented. And now let me introduce the basic facts related to GI genes, so to the AI system developed for colonoscopy that we are talking about today. So the system has been developed by Cosmo Pharmaceutical, is marketed by Medtronic worldwide, it's been already approved by CE Mark, so is available, fully available in Europe and Middle East. And there is ongoing trial led in the United States by Mike Wallace and Pradeep Sharma for getting the FDA approval, so to be used into the American market. So it's very easy to be integrated in your workstation. It works with any kind of scope that you are going to use, from Olympus to Pentax to Fuji to Sonoscape to Storz. You don't need to use a second display and seamlessly inserted into your video chain, so very easy to be adopted. So these are data on how the system has been developed. So the neural network has been engineered to perform a very robust analysis and detection, even in difficult situations like when the light is not very clear, when you have full bowel prep or you have colonic spasms and movement. So the data set started with a huge amount of pictures of lesions, has been also trained with a lot of videos, and there's been a special data set of potential false positive images just to make a more robust system and avoid the false positive. So this is very important. I want to show this video. So just forgive me if I use my Endoscopy on Air creation, which I'm very proud of. I'm co-chair of Endoscopy on Air together with Thomas Roche. And look to the GI Genius performance. You can see how robust is the training that has been adopted for the system. This is a patient with a very nice bowel prep, but the issue is that we have a lot of bubbles. You see there are these green marks showing that the system is on, but despite there are so many bubbles, there is very minimal activation of the superimposed green box of GI Genius. What does it mean? The GI Genius well recognizes that these are not polyps, and these are false positives. So this is extremely important because sometimes when you have this kind of bowel prep, we have bad bowel prep, the system can get noisy, you can get annoyed because it's not working well. This is not the case of this GI Genius system. So let me go to next. So very briefly, what is the history of this project? So first I have to congratulate to the two geniuses which are behind the GI Genius, these two guys, Jan and Andrea, who worked for Linkverse, a subsidiary company of Cosmo, and they were very smart. They were in charge of the video recording system of a pivotal trial for colonoscopy using medical blue and white light. They used the videos, and one day they came to me and they showed this beautiful, sensational AI system. It was 5 years ago. I was totally ignorant about AI. And when they showed, I was so excited. They got the feeling there was something very, very big because they looked to my eyes. They recognized they was really astonished. They progressed from 2013. You can see there is a lot of work behind that. They have been extremely good. And they went to the final system in 2018, and they call this a game changer. So it's important to remind that the videos they have used, they come from the most expert centers in the world. About 20 centers, they provided videos with a very high ADR and a very difficult situation, very difficult polyps. And the also very important point is that the system has been trained using videos from Olympus, Fuji, and Pentax, from the three most important vendors available into the market. And this is why the performance of the GI Genius is so spectacular. So let me go quickly to a couple of videos. This is sort of ghost lesion. You can very nicely see how the system is addressing, is targeting an area that looks normal. Indeed, we are into the right column. I'm using different system, different modalities of chromoendoscopy, including conventional chromoendoscopy. And you can see this is a tiny, flat, sessile serrated adenoma into the right colon. Again, very similar situation. So especially into the right colon, the system can allow you to avoid that missing of polyps that has been probably the main reason for interval cancer. So this is my final slide to say that the system is organized to train itself thanks to the millions and millions of images and videos that are provided with the users. So there is a continuous and ongoing improvement of the system that is going to allow us to see any kind of minimal mucosal abnormality. So now,
Alessandro,
yeah, Cesare.
so we have a lot of friends from everywhere in the world, and I guess that there is a different variety of competence among them. Is the genius something for expert? I mean, high detector people crazy for finding polyp. Is the genius only for trainees or low detector because they need it? For instance, you're an expert. Do you use it every day or you use only?
So we're lucky. We were the first in Italy to got the system. We have the system in all our units, and I think it's a nice system to democratize ADR. And when I say democratize, means that there should not be in any place top detectors and low detectors. There should not be high ADR in the morning and low ADR in the afternoon. There should not be poor ADR because Inter Milano was defeated by Real Madrid yesterday, or there should not be high ADR because the other team, Chelsea, is going well. So regardless of the operator, regardless of the scope, regardless of the situation, the AI system in the future will allow to have a very flat curve. Everybody must be on the top of the bar. And this is the only way to provide to our patients situation where we can say, okay, we did your colonoscopy. We know we didn't get polyps, so we just got 3 minimal polyps. You can safely go to 10 years interval follow-up. So this is extremely important to me.
Ale, so you use it in everyday practice for all the procedure?
Absolutely, yes.
Pradeep, do you use it every day in all your procedures? When you have it, of course.
I have to say that when we first got the system almost now a year ago or 9 months ago, I thought maybe I don't think I need it. We find a lot of polyps. We started using it and we found that it became very, very useful. Although you can see the polyp, but it was very, very quick in helping. So it's now a standard for all our rooms, wherever we're doing endoscopy, we're using an AI. And it's being very well appreciated by a lot of my colleagues, seniors as well as juniors. So I think there is no hierarchy here. It helps everyone.
That's democratic.
Yeah, so I think we have the first question to be answered from everybody. So David, can you launch the first question, please?
We have people from everywhere in the world.
That's great. Welcome to everybody, guys. It's so lovely to have all of you here with us. So what is the question is, what do you believe is the main point, the main advantage of adopting artificial intelligence for polyp detection or colonoscopy? Please answer. Okay. So everybody agrees that this is big support to increase adenoma detection rate and to democratize adenoma detection rate. So don't tell to Trump that everybody will be the same and everybody will be very good. And to prevent miss rate during distraction is also, I think, is a good point, because regardless of your skill, there is a moment, there is a time of your working day where you do not have the same level of attention. This is human. The difference between us and the AI is that we are not artificial. So we have up and down. Artificial doesn't have any change. It can replicate our task on a regular basis. Much faster, much better. You agree on that?
I fully agree, Ale. Because for instance, if you are already a high detector.
Let me say there is a guest from India saying that in India is almost midnight. We welcome our Indian guest. Thank you for joining us.
Okay, Ale, imagine Dagrex, okay, he has an ADR of 70%. I don't feel he need to go to 80% or to 85%. He only need to be sure not to miss a polyp. As you said, only because Inter Milan lost with Real Madrid. I apologize to remind you that. And I think we want everyone to be high detector, but also high detector not to miss polyp. And this is the why Ale Repici and Pradeep Bhandari use GI Genius in any procedure, because despite they know they are the best, they know they can miss for any possible reason.
Let's go to your presentation. I want just to say there was one of the guests, one of our guests saying that consistency is the right word. I love consistency because it gives the feeling of what AI is. And there was another question asking about upper GI endoscopy and enteroscopy. I think we can announce that soon there will be available also AI system for upper GI endoscopy. And I know that Medtronic is strongly working to provide also a system to guide enteroscopy, AI system to guide enteroscopy after capsule endoscopy, but this is the future to come. Right now, I want to get some information about clinical data. So Cesare, this is up to you now.
Yes, thanks, Ale. The idea of deep learning is that it is not Pradeep to tell the computer what a polyp is. On the other hand, the computer self-learn directly from a data set of polyp what a polyp is. This is deep learning. It's a sort of automatic learning. So you provide the computer with the data and the computer learn. Here you see how Nyan and Andrea were annotating the polyp to tell the computer, this is the polyp, you need to learn how a polyp is. So if this is deep learning, can you give me the next, Dave? And this is the output of the system. Next again. So if AI learn from data, we need to be confident on the training data set. And this is not about GI Genius. This is about any AI in endoscopy. You need to ask who trained this system, what data were put, because of course there may be several pitfalls in this training. Go to the next. For instance, it may be a selection bias. Maybe in training this system, Ale only selected very beautiful images, and so the system does not detect those blurred. Next, there may be an operator bias. If only 2 endoscopies did the training, the system memorized what the 2 endoscopy did, but did not learn. There is a difference between memorizing and learning, and this is about the training data set. Next. And if you put too few data or too much homogeneous data, the system memorizes, but the system does not learn. Next. For this reason, what you need to look is in the training data set. And here you have the magnitude. When I say magnitude, it's not only quantitative. So, oh, congratulations, Ale, you have nearly 3,000 patients in a GI Genius. Not so much that. But for instance, I'm very happy, Ale, to read that you took cases by 20 centers. This is extremely important, that this data set reflects the practice of several other endoscopy that maybe are closer to your own practice than Alessandro or than myself. This is what I like of GI Genius. So not only quantitative, but also qualitative magnitude. Next slide. So Ale told you that we use this data set, but let's get a bit deeper, Ale, in this data set. For instance, this is the number of polyp, but you may see that most of the polyp are 0 to 5 millimeter flat lesion that are exactly what represent today half of ADR. Half of ADR is represented by small flat lesion in the proximal colon. And this is where the ESGE Genius was trained. For instance, Ale, I could tell you, but you put only a few over 10 millimeter polypoid lesion. That's true. But it is also true that US endoscopies are expected to find very big lesion. You don't need a GI Genius to detect 3 centimeter pedunculated polyp in the sigmoid colon. So this software was created with some finality. You need to know what this finality is. For instance, Pradeep could be interested in having a software with a lot of flat lesion, because to detect flat lesion is also important. Then Ale, another consideration, when you buy an endoscope, it's a finalized technology, okay? You may have high definition, advanced imaging, blah, blah, blah. But this is the first training data set. I guess, Ale, and I want you to comment on this, that probably this data set will evolve and there will be several other new software that will be delivered with the GI Genius in the future, correct, Ale?
Absolutely. The system has been trained with other thousands of videos. There is already a new version that's going to be released at the European level, and another release will come in 6 months. So as you can see, it's an ongoing war. Never stop. Never stop.
Yeah, this is why you need to choose artificial intelligence, because it will grow up with you, like the iPhone that is updated any month. So this system will be updated.
There was a question from participants saying, there is any risk of de-skilling the juniors guys? No, I don't think so. I think there is a risk that you improve their training because they understand better what they have to look for, much better.
Yeah, Ale, I was so disappointed today. My fellow who did the colonoscopy with GI Genius for 1 year, in 1 year, he has the same ADR of myself. I spent 30 years to increase my ADR. And this guy, he proved GI Genius in 1 year. So people, why do we have to...
Pradeep, be ready to offer a position to your Cesare friend. So he's going to lose his job. Please,
you need to stop this
position open.
Okay, so
I think that's one of the biggest advantages that you just highlighted, is that now it is not a lottery for patients. Patients can confidently go to Milan, to Portsmouth, to any center, and be assured that if you have AI working in the background, they will get a minimum standard of service. That will be guaranteed. So that's the beauty of this.
Okay, but I want to be precise on this, because most people are scared about this de-skilling. Ale, you told me something about your practice. Did you decrease or did you increase your polyp detection rate since you are using GI Genius?
Let me tell you, I have 2 different experiences. So I work until Thursday in a public hospital, private hospital, but open to public system. And we have a system for recording ADR, and we receive every month. So we had the spike, which is now on plateau since the adoption. And the spike was consistent with all physicians doing colonoscopy. So, but the other big point is that on Friday, I work in a private practice in a private facilities where at least 12 different colonoscopies, they used to go over the week. They have a different slot of time. And we adopted again also in this facility AI, and I compared the data year to year. So also in this situation, the increase of ADR was even more consistent, even bigger. And there was with the 12 different behaviors of doing colonoscopy or treating patients. So absolutely very stable effect, a very consistent effect.
Okay, so guys, we categorically exclude any de-skilling effect by AI. It is exactly the opposite. We can promise over-skilling effect. You can find any defect in AI. I'm the first to support, but not de-skilling. So Dave, can you go quickly to this slide? So this data set was...
Can I just make a point about skilling? I think we all agree that AI will perform better in the hands of endoscopists who have good colonoscopy skills, and it will not perform as good in those endoscopies whose colonoscopy skill is not good.
This is to respond to the point made by Stefan Bien, who is saying that you need to expose well the entire surface of the colon.
Completely agree.
Yes, Ale, can I say something about this? Of course,
Yes, sir.
I feel guilty if I don't expose all the mucosa. But you know what? I feel even more guilty if I expose a polyp and I didn't recognize. So at least
Right.
AI remove this guilty effect of a real mistake by the endoscopist. Next slide.
That's right.
Okay, so before this slide, Dave, you should launch the second poll. We have an incredible audience today. I don't know how to thank all the participants. Please, Dave, launch the question. So this is about how we decide to validate GI Genius. All the people said, oh, it should increase ADR. In a lot of chat, there is ADR, ADR, ADR. Is this the right way to go? Okay, there are a lot of questions about cost. We'll take this later, don't worry. We don't escape anything. Okay, all of the above. So, guys, when we started to consider how to validate GI Genius, we took it simple, because GI Genius should only recognize a polyp that is on the screen. Detection, go on, Dave, is a much more complicated issue. Detection depends on a lot of issues, withdrawal time, disease prevalence, and blah, blah, blah. The only thing that GI Genius can do is polyp recognition. So the question is, how many polyp does GI Genius recognize? Next slide. Next slide again. So this is the so-named standalone performance of GI Genius. If you give 100 polyp to GI Genius recognize 99.7 of them, and this is against the performance on the other system. Before I go here, Ale, someone could say, does GI Genius detect the polyp after the endoscopies or before the endoscopy? It's very disappointing if I find the polyp and then GI Genius only confirm. You want GI Genius to detect the polyp before. I don't have here the slide, but maybe Ale, you can comment.
I just want to give you my feeling is my eye is the speed of a Fiat, and the AI is the speed of Ferrari, so there is no competition at all. Zero competition on that.
Yeah.
So also the number of frames that my eye can analyze per second is very limited in comparison with the GI Genius. So, Pradeep, you know how many frames per second are generated by colonoscope?
I think it's about 50.
50,000.
In
a second, you mean.
Frames can get your eye per second?
Maybe about 10.
Probably less per
Yeah.
second.
I agree.
So
Yeah, this is very. Yeah,
so
that's very.
the eye can get all of them.
Yeah. Okay, we move quickly to the last part of the presentation. That is what you were so much anxious to know. So, if it is good, it doesn't mean that it helps. Because, for instance, if Pradeep detects all the polyp, even if GI Genius is good, it doesn't help. And so we need to do a randomized trial to understand if what is true positive for GI Genius is also for Pradeep, what is false negative for GI Genius maybe become true positive because Pradeep missed. And if there are false positive, what happened? There are a lot of questions about false positive. So go to the next slide, Dave. Go to the animation. Okay, so this is the randomized trial that Ale did here in Italy. It is the first and this said the only Western setting study on AI. People were randomized between standard colonoscopy and colonoscopy with AI. And there was a dramatic increase in the adenoma detection rate. That is something that you was expecting. And there was also a 46% relative increase in adenoma per colonoscopy. Maybe, Pradeep, you want to comment why adenoma per colonoscopy is somewhat replacing ADR in terms of quality of colonoscopy?
That's a very important point. I think in the past, it was difficult for us to calculate histology, to find, and then put it back into the colon and measure. So ADR became a very useful marker. But the problem with ADR is you can detect one polyp, one adenoma in a colon, and then you can't be bothered about the rest of the adenomas, because as long as you detected one adenoma, your ADR goes up. Whereas the best marker is, and truly speaking, a patient who has 1 or 2 polyps is a high-risk patient. You're likely to find more polyps in that patient. So it is very important that we pay more attention to the colon where we find 1 or 2 polyps, because your likely gain is very high. So the best marker is polyp per patient, because whenever you find 1 polyp, there'll be more polyps, so look carefully. And that's what I think differentiates men from boys. So a good colonoscopist will have a very high ADR as well as polyp per patient, whereas an average colonoscopist can have a very high ADR, but when you look at their polyp per patient, you might find a lot of variation.
Okay, Ale, before I leave this slide and this study, there are a lot of questions about hyperplastic polyp. So is now Alessandro Repici wasting his time because GI Genius show useless hyperplastic polyp that he need to remove? So in this study, in the AID study, did you find an increased resection for non-neoplastic lesion? And what about your practice?
No, I would say no. So this is, I would say, confirmed by the fact that the withdrawal time was exactly the same. We had a very limited number of false positives, and we adopt the same policy that we adopt in our practice. So if we see multiple hyperplastic polyps into the distal sigmoid rectum, we try to make histologic prediction with the chromoendoscopy. Once we define that they are smaller than 10 millimeters, they have features consistent with the hyperplastic appearance, we just remove 1 or 2 of them just to have histologic confirmation and nothing else. The same we have done with the GI Genius, nothing else.
I really like your point, Ale, because some of the questions say, oh, look, is AI going to kill advanced imaging? No, you need advanced imaging to discard useless hyperplastic polyp. And I feel that on this, all of us agree.
It's also important that there is still a human factor. There is a human responsibility in that, and we need to take the responsibility. So AI is helping, is directing all the abnormalities of the lesions, and that's your job. That's where your skill counts, because this is where you have to say, okay, this is to be resected, this is not needing any resection.
Yeah, I like this fact, Alan, then I give you to Pradeep. AI is not going to replace us. It's going to make us even more important. At the end, you need to be overskilled in detection and characterization. Please, Pradeep.
Well, I was going to say that this is a very impressive data showing a very good increase in ADR and APC with nothing. Endoscopist has to do nothing else. You don't have to attach a big cap or a device or a retroflexion or nothing. A simple use of AI along with your colonoscopy results in such a massive increase. And I would like to remind our audience again about the significance of ADR and APC. Every 1% increase in ADR reduces the interval cancer rate. So this can have a big impact. One of the questions which quite rightly a lot of people have asked is that it is increasing a lot of small polyp. Is that going to make a difference? And they're quite right in pointing that out, that it detects a lot of small polyps. The reason is those individuals who have very high ADR and high APC, they do detect a lot of small polyps, and they are the same individuals who have a very high detection rate of non-granular LSTs of sessile serrated polyps. So this is all combined. You cannot dissociate one from the other. Those who detect a lot of small polyps are also the same individuals who detect a lot of flat lesions. So this is all linked up. You can't isolate one and say, well, it just detected a lot of small polyps, it's not going to help me. No, it doesn't work like that.
I fully agree with you, Pradeep. The ADR is a technical, not a clinical indicator. ADR means that the endoscopy is good, not that by removing all these molla, he will prevent cancer. As Pradeep said, it is because you also detect advanced neoplasia if you have a high ADR. Okay, next slide, Dave. Okay, this is only to show that all our classification will probably become prehistorical. What is difficult for a human mind, for instance, the non-polypoid appearance, as Pradeep was suggesting. This is not a problem for the computer. Maybe the computer will have problem that we didn't have, but for the computer to say proximal distal, small or big, doesn't make such big difference to A, to B, to C. And so probably most of this for the computer is not an issue. So we need to rethink all our classification, etc. Next slide.
We are running a little bit out of time, so I need to invite you to go to your conclusions because we need to move to Pradeep.
Yeah, Ale, but this always happens with me, so don't worry. We will end in time. So. Okay, so this is the last slide. That is about the false positive. So
there were a couple of questions from participants about false positive, so you can answer to all of them. Thank you.
Yeah. There are a lot of issues. I see a lot of worries about AI. It's not dangerous, guys. It's not a problem. It's something you can have like in a car on your iPhone. So we show that the mean increase in withdrawal time is only by 10 to 20 seconds. So 0.7% doesn't mean anything. It's between 10 to 30 seconds, okay? But colonoscopy is about 6 minutes in insertion, 7 minutes in withdrawal, 2 minutes in polypectomy, and 30 seconds for AI. Next slide. And now, Ale, this is important because there are a lot of questions about money, because money is money. So is it worth? This is the cost effectiveness. I want to pay tribute to.
If you share with me your paper, because this is beautiful analysis, but I see only the slide. I never saw the paper. Pradeep, yeah. I'm going to be a little bit jealous of this guy.
Of this slide, not of this guy. So let me say thanks and ciao to Yuiki Mori, who joined Europe from Japan. He really invented the first AI system in Japan. And we are working together on this model, showing that it is a dominant procedure from cost effectiveness perspective. So even if you assume to pay about $10 per endoscopy, the saving you have from cancer prevention, as Pradeep was suggesting, is dominating. So this is one of the most wise, convenient choice you can do in your practice. But now Ale said, I need to shut up. Okay, thanks, Ale. We can move on.
Thanks. It's been beautiful as always. So Pradeep, now is your time. Please to be a little bit better and less artificial than Cesare, please.
Perfect. So I have a very simple task, guys. All of you heard all the clever things about deep learning and ADRs and things. I'm a simple endoscopist. I will show you a lot of videos and we'll go through some basic messages. So this is a common question. The AI can be a big nuisance. So I just want to show you a real-time video. AI is active. I don't see any nuisance. Do you see? AI is not coming up, not obscuring my views. Nothing is happening. We're going through the colon very happily with an active AI system. So there is no nuisance. There is no huge false positive. So all those questions that we had, you can feel reassured that this doesn't cause nuisance and it will not annoy you. Okay.
Yeah, Pradeep, very important. You don't need to modify your technique. There is no delay. You don't need to change anything. You only switch on and that's all.
I completely agree. And don't worry about nuisance. It will not cause any problems. Again, false positives. This is, I think, for me, it's a philosophical debate. Technically, what is false positive? And then what do you do with false positives? So how we define false positive, in my view, if it shows a green square and it's a persistent square, and that despite you going close and assessing properly, this kind of little square coming and disappearing is not false positive. This is just the fold, it highlights, you should look at it, but you know, now that little area, it's shining. Now when you go close to it, it says it's no polyp. But it's very important that I go close to that area and evaluate it, because small polyps will look like that. Now we coming to, this is cecum, and as we come back, you see a lot of folds and intermittently these squares come up. There's nothing wrong. I don't call that as false positive. If there's a bubble and the square comes up, it's a duty of an endoscopist to evaluate to make sure there's nothing underneath that bubble. So again, I don't call that as false positive. I think these squares basically make us a better endoscopist, makes us evaluate the mucosa a lot more than what we normally do. And that's why our detection rate and performance will improve. And hopefully I'll have a video to show that to you.
Pradeep, wait one
now we were talking.
I really like that while you were in the cecum, there was one square on ileocecal valve. Do you feel that in the future, AI could standardize the reporting of endoscopy? Yes, Pradeep, you were in the cecum because AI detected the ileocecal valve. So do you feel that AI can somewhat standardize all our procedure, not only polyp detection?
I think you already stolen another of my slide. There was a video which was going to talk about exactly that. That
Sorry.
AI is pretty good in recognizing that landmark. At the moment, it considers that as a polyp, but we can feed AI, as Ali was saying constantly, a range of these pictures of ileocecal valve, and then it will call it ileocecal valve. It will not call it a polyp. And then we know that we reach cecum, and then again, when we reach the rectum and you've done a retroflexion, it will recognize you at the anal sphincter, automatically gives you a withdrawal time. So we only need to train AI in these two landmarks, and it gives you that. So I think you're absolutely right. This is where I think everybody will go. This is just a beginning. These false positives, I think we have already covered. So let me move on to the latency. So this was also one of the questions asked by colleagues saying, is it quick? Now that was quicker than me. That's what Ali was trying to point out, that it detects the polyp before I can see it. And when we first got it, I was really competitive. I really wanted to find the polyp before AI, but unfortunately, it doesn't. Only when you're far away, maybe humans can see a bit better than AI. But as soon as you come close to any polyp, AI picks it up before us. So you know the figures on latency period, Cesare. Do you want to tell us?
Yeah, there is a 20 millisecond difference in favor of the linears. Of course, we cannot measure, but yeah. I also came down to your honesty that we are slower. And I agree with you that when the GI Genius detect a polyp, I don't feel any more competitive. But I can tell you something, Pradeep. There are few times when I detect the polyp before the GI Genius. And in that time, all my competitiveness come back and I say, yes, I'm so proud of myself because I detected the polyp before the GI Genius. So we pretend not to be competitive because we lose like Inter Milan, but at the end, we are always competitive.
Well, let's not drag Inter Milan here. I think we need to keep Ali in a good mood.
No fail, no fail.
So now this is the most important question. This is a great device. It's artificial intelligence. It is not true intelligence. So that's why it's a very valid question. Because it's artificial, it's been fed polyps. Will it only recognize those beautiful polyps it was fed? Or will it recognize polyps in a normal colon? I don't know, Cesare, how the colon preparation is in Italy, but in UK, almost 30% of our patients don't have a good bowel prep, despite everything we can do. So let's see how it performs. So this is what I say is not a good bowel prep. I'm in the CCAM. It says not good. Now, is this false positive? That's what we thought first. It's false positive, but we couldn't ignore because every time we go, and now you can see it looks polypoid. We wash a little bit and there is a polyp. So despite all the poor bowel prep, it can find polyps. And that was extremely reassuring for me.
That's very important, Pradeep, because when the bowel prep is bad, we feel demotivated because it's somewhat the patient to be guilty. It is not us who miss the polyp. So I fully agree with you. The hygienist has a different attitude in this case. Very important point, Pradeep.
I like this idea. He's absolutely spot on that you feel demotivated and angry and you say, oh, is this patient wasting my time? I'm such an important person. And you know, you did not take a bowel prep, you're ruining my time. GI Genius has no ego. You know,
exactly. Yeah, that's the difference.
Did you never get the bowel prep for yourself?
I have. I know.
Can you make a comment on that?
Well, you know, bowel prep is not the most pleasant experience. It is very painful. I think taking bowel prep is more painful and uncomfortable than having a colonoscopy itself. So I think we should not disregard that, especially in elderly patients whose mobility is also not very good. You know, so it's a very difficult area.
Cesare, what about you? What about you? Did you get any bowel prep?
Ale, I was a pioneer. I had colon capsules, so I had 6 liters of PEG and 2 sodium phosphate.
This guy is always top, number one. This guy is always above any kind of limit.
Ale, are you going to match GI Genius with colon capsule for my next screen?
That's the next step. This is what we're doing. This is what we're working with.
I'm going to do it.
So just carrying on the theme of poor bowel prep, it is important that we make the right decisions. I'm washing and you can see it's almost was invisible. Once it highlights, as I was saying, once you find one polyp, there are lots of other polyps. Just look at that. It will show you as they come into the frame, there are lots of little polyps around. So that's the beauty. The bowel prep is bad. There are multiple polyps. I now immediately know what a decision I have to make is I have to bring this patient back for a colonoscopy. As simple as that.
Pradeep, I feel this is a very good point. When we see a polyp, our focus gets restricted on that polyp and we don't see anything around. On the other hand, GI Genius continue to see around. So it is a different perception attitude that make GI Genius complementary with our mind. So great video. GI Genius can detect simultaneous polyp with no problem.
Yeah, absolutely. That's a very common problem. Okay.
So, you know, guys, what has been my feeling that also GI Genius nicely recognizes SSA. So despite most of the training programs for these systems, they have used the adenomatous or sessile, typical sessile morphology. So my feeling with the GI Genius is that SSA are fully recognized. You have the same feeling?
Yes, I definitely have experienced that it does pick up SSA really well. Yeah.
So probably there should be a research program on that supported by one of the ESGE awards, no?
I agree. I think some people are already writing a grant application for that.
So Pradeep, can you tell us, because we are going to the end, before you show this video, can you tell us a few words about the details of the ESGE awards supported by Medtronic?
Yes, I was going to come to that very quickly. So basically, we have a huge amount of support coming from Medtronic in the term of financial support, as well as GI Genius boxes available. So ESGE is already advertised an open grant application. We would encourage everybody to apply and think of very clever ideas the way in which you can use AI to improve patient care, whether it's about surveillance intervals, whether it's about sessile serrated polyps, whether it's about training. There are lots of ways in which AI can influence our practice. So if you have a clever idea, and preferably a multi-center idea, we would encourage you to apply to ESG for this grant. We will provide you with GI Genius boxes for whatever centers, how many centers you want. We'll give boxes for those, and we'll also help you with some financial support to get the research off the ground. The last date for application is...
How long the research must last? For 1 year, 2 years?
Well, 2 years is too long. It will all depend on the sample size and the question you're trying to answer. But I think ideally we would prefer that most studies are started and finished within a year.
Can you tell us altogether with Cesare how you make a decision which program will be supported, how you pick the best one? There is a commission, there is a committee, how you do that?
Pradeep, you are responsible.
I can answer that. So basically, the research committee of ESG has been assigned the task to collect all applications. We have a very clear review process. So every application that comes in, we have a validated review process. So we will send it out to external reviewers who will review your grant proposal and will mark it. And if everyone's and all the marking will be added up, so the top people will get the grant. The last date for application is 30th of January, and we will announce the results sometime in March. But this is only the first round. Then there's a second and a third round coming. So lots of grants we want to give. We want to do a lot of research and promote this. So please keep your ideas coming. Everything is welcome. Nothing is small. Nothing is too big. So just don't hesitate. Keep coming.
Can you say a few words also on next ESG days? Because we are all missing beautiful meeting ESG days. And what is going on with ESG days?
Yeah, this is very important, Alessandro, because artificial intelligence is completely new field. So for all the young researchers, this is the opportunity of your life, and you can submit your abstract in ESG days 2021. Of course, Ale, it is going to be virtual, but there will be the same number of oral presentations. So all the abstract will be published on endoscopy. Nowadays, the first journal is Impact Factor in the field of endoscopy. We need to pay tribute to Peter Searsema, editor-in-chief. So all abstracts published and the same number of oral presentation with Pradeep Bhandari and all the others to look after that and to discuss. So there will be a lot of novelty innovations in the most influential meeting on endoscopy in Europe.
That's lovely. Thank you for providing all this useful information. So can you show a couple of videos, because we are close to
quickly. So this is, just see, there is a polyp there, and there is an area you will see. I've moved on. So what I was trying to say here was that water flushes do not, so because we do a lot of underwater colonoscopy these days, so you can see, you can go underwater, it will not miss polyps, and it will not cause a lot of false alarm.
That's a very good point.
Polyps underwater, no false alarm, so don't worry. This is a very subtle abnormality on a fold, looks like a polyp. I was thinking, what is this? Is this a polyp? And it does highlight it as a polyp, makes me examine it, bring close, assess it properly. It did turn out not to be a polyp, but definitely looks like a polyp, and it's worthy an endoscopist assessment. So again, don't ignore this. I'll move on from this. Just it always will find. This point we've already covered, IC valve and all that will become a future thing. The important thing I want to say is I showed you a lot of videos with Fujifilm. These are videos with Olympus. This is the Lucira Elite 290 and 190 platform, and it works very well on Olympus. You see that? It detects on Olympus just like how it did on Fuji. Similarly, what I want to show in our next video is Olympus has now launched a brand new platform called X1, and there's a lot of anxiety whether it will work or not. Here you can see on X1, it's working very well. That's false positive or a bubble, but that's an adenoma there. You can see it detecting the adenoma very well. As we come back in the same patient, I think I find another polyp. There you go. It's a large polyp. It finds large polyps as well. So it works really well in X1. Now, this is very important. Can both of you please pay attention and tell me what you see? So this is I've just seen this video today. A colleague of mine done the endoscopy and say everything was normal. I was assessing these videos and everything was normal. Did you see anything other than?
No, I agree. Everything is a fold. It looks like a fold to me.
Oh, okay, so it's a real fluid fold, all sorts of things, but Genius did flicker. So now what I've done is, Cesare, just to help you, just for you, I've slowed down the video rate. Watch this video again. It's exactly the same video. I've slowed it down. Now tell me what you see.
Now I can see a border. Yeah, now you're right. Yeah. Now I can see the apoplastic polyp. Only your eye, Pradeep, could detect that. Even after the Genius.
So this was a procedure done today by a colleague of mine who has this bias in his mind that all these AI things are nonsense. They produce all these rubbish squares. They're distracting. They don't help. You see that? There was a flicker. There was a green square.
What did your colleague say afterwards?
I haven't met him because I just assessed this.
I hope he can change his mind. We need a public declaration.
Well, you know.
Pradeep, no, let's stop. Pradeep, you have showed what Ale was mentioning before. The GI Genius elaborate each frame. The human mind is unable. You were clever because you slowed down the video. So it's very important in the future, and this is from Medtronic, that it will show the picture where the GI Genius depicted the polyp. Do you agree, Pradeep? This is
Absolutely.
very important in the future because maybe the human eye just missed that
Absolutely.
photogram because it couldn't detect.
You know, thankfully for this talk, I reviewed the video today. Now this patient will need a repeat colonoscopy.
Yeah.
Oh, listen, my Genius friends, I am a little bit hungry. Everybody's going to be hungry. I want to go.
One last minute, one last second.
I want to make a point.
Last point.
Last
I want to make a point, a last point.
Okay.
So, people, you realize that Pradeep Bhandari, of course, has any system in his unit, Fujli, Olympus, Olympus Old, Olympus New, Pentas, etc. Pradeep, with one AI device, can apply AI on any platform. So he can move the GI Genius from the Pentax to the Olympus, from the Olympus to the Fuji. So this is why, if you have multiple systems, it's better to have one that is universal. I know, Ale, that
He brings
is very important.
From the house, from everywhere.
Very, very important. So we've seen AI, if it sees a polyp, it will find it. If it doesn't see, it's not going to find it. So I think the future is combining AI with some mucosal exposure technique like endocuff, like CAP, whatever else. And I think that can improve the performance and standardize the performance even more. So it's just highlighting the future that we can improve our colonoscopy exposure technique with these devices and then let AI detect the polyp. So that's the future. I'll end it there. But I think that's the most important point that Cesare highlighted is this is a universally applicable device which can work with non-patented technology, simple white light on any system. So that's the beauty of it. And I'll stop there. Thank you very much, guys.
Thank you, Cesare. Thank you, Pradeep. It's been a real pleasure. It's been a nice discussion, a lot of interaction. I love to see you smiling, guys. And I want to say that we are so grateful to ESGE for providing these webinars. There are several to come. Also next week there is another one. So ESGE is doing a great job. We so grateful also that big companies like Medtronic can support this space at this time. And I hope everybody can stay safe and hope to see you next week to next webinar. Please pay attention, stay safe.
Thanks, guys. Thanks, Ale.
Ciao.
Bye.
Ciao.
Thank you.
Bye.
I think you answered most of the questions. So thank you very much.